Hello, everyone. Thank you for joining us again. I think that we still have some people joining us and trickling in. I'm keeping an eye out on the uh, on the what you call it on the waiting room. So you might see me moving my eyes towards that. But let's get started. And Megan. Today, we have a really great webinar for everyone. We're very lucky to have several speakers with us today. We have Cassandra
I'm in a webinar, but isn't this? No.
From American Heart Association, and she's going to be moderating the panel discussion. And we have a couple of great speakers with us as well. We have Dr. Alvin, she's from UT Southwestern Medical Center, and Diane Jackson. She's from the North Texas Area Community Health Center. So I'm gonna let them introduce themselves as they also introduce their programs and their work. So for today's objective, we have a couple of them. We're going to be learning why it's critical to support patients with food RX interventions at the health center point, and address food insecurity and different chronic conditions, as well as understanding the process to start a program directly with some real life promising practices that we're gonna have them share with everyone. And we're gonna gain access to different TA and tools and different resources that are available for you to implement your program. So first we have to go into what is Food RX programs. Food RX, it has different names: food prescription, healthy food programs. Different names are used for it, but the main thing that we are trying to address with it is food insecurity. So there's a well researched connection between food insecurity, stress, and chronic disease. So including diabetes. In fact, adults who experience food insecurity are 2 to 3 times more likely to develop type 2 diabetes. And those who already have it, management becomes so much harder, right? So they don't have access to nutritious food. And as everyone knows, diets that are high in fruits and vegetables, and the fibers that they contain are associated with lower rates of type 2 diabetes, or better controlled. But since people with diabetes also have additional healthcare costs, so it becomes a little bit more difficult for them to manage the cost, and they often are put in a point that they have to make a decision of their healthcare costs, or getting the healthier food, nutritious food that they need. So that is the constant battle that many of our patients usually need to address and decide on. And that leads to, getting cheaper food, and many of the cheapest and more plentiful foods in our society are also those that are more likely to cause chronic disease. So they're high in added sugars, they have saturated fat, and high in sodium. So additionally, there's a link between many chronic diseases, including diabetes, and the stress that is associated with struggling to find or afford enough healthy food. So all these are the causes of the problem, and we are looking at what, due to all these reasons, what is an intervention that we can do. A food RX intervention, which addresses the affordability of fresh fruits and vegetables, is essentially helping us to achieve a health equity for people with chronic conditions, especially those who have low incomes and have a difficult access to it. Studies on food RX programs are starting to show more notable clinical benefits, including reducing A1C levels, improving blood pressure, reducing body mass index scores. It decreases food insecurity and decreases depressive symptoms as well. As overall health management. So the benefits are several, and in addition, it appears to result in better self-reported overall health as well, eh, with a higher consumption of fruit and vegetables as well. So addressing food insecurity in healthcare is a very particular intervention because it addresses the root cause of disease that we are usually trying to treat downstream in the healthcare system. This rather moves the intervention upstream, and its value lies in improving social determinants of health, improving overall health, improving costs, keeping costs down as well. So, in fact, just recently, a lot of literature has come out on the cost effectiveness of this type of interventions. Uh, one study, in one study, it was determined that Medicare and Medicaid participants receiving a 30% subsidy to reduce the cost of produce would over a lifetime result in $39.7 billion saving in healthcare costs nationally. So there's no question that these interventions work and that their cost effectiveness of it. And we're hearing more and more about it in even the national discourse about. So we at NCFH, uh, sorry, we at NCFH, our purpose in we created a Food RX replica guide, and the purpose was to address the needs that we see in health centers across the country to reduce food insecurity in their patient populations and reduce the incidence of diet-related disease, reduce the cost of care as well. So decided this guide we designed this guide to be as user-friendly as possible to help you implement your own FoodRx program. And we created it to be comprehensive, step by step, and keeping in mind that health center staff often have limited resources and time at their disposal. So we wanted to create something that allowed health professionals to address food insecurity as a modifiable health risk. And you can access it in our website, and that's the link to it. And I'm also going to be putting the link in the chat for you, and we're also going to be sending it in a follow-up email. So hopefully you get to see it, read it, and use it, most important. So with that said, I wanted to uh, introduce to everyone to Dr. Alvin. And Dr. Alvin, whenever you're ready.
Great, thank you. And you can see my slides, correct?
Correct, great.
Awesome. I get an A for my technical skills today, which is not always true. My current approach is to ask one of the teenagers in my house when I can't figure it out myself. Okay, I'm excited to share with you today, and I'm going to actually dive right into my next slide and tell you just a little bit of my story because there aren't very many physicians who have dedicated their career to this work. And I think it's because of the missing piece of nutrition in most of our education. And I always remind people, though, that using food in a way that improves health should be relevant to everyone because we all eat. And there's literally no one that isn't impacted by food or family health issues related to food. So, taking it back to my early days, this is my grandfather, and I'm with my sister here. I'm the older child on the left with the red baseball cap on. And this is on my grandfather's farm in Texas. And actually, all of my grandparents were farmers, and I grew up learning how to harvest food and grow my own food and cook food that we freshly picked, and it was a huge value to my childhood. And so I care a lot about farm worker health, just having grown up with the experience of even health conditions related to their farming work that my family members had. My parents actually moved to the city, as they call it, when I was sort of in middle elementary. And so my parents were not in farming and moved into education. And I always wanted to find a way to honor those roots. And I didn't realize how it would come about until more recently. So, as the first person in my family to go to graduate school, I didn't really know what I was doing. And I also didn't really know what I was missing when there was no education about the connection between food and health. So, I became a primary care physician. Here's me actually with my residents. I'm a clinician educator because the people in my family that were not farmers were teachers, and I wanted education to be a huge part of my work. And I'm an internist and a pediatrician. So I ended up entering academic medicine, and my first job after residency 11 years ago was coming to UT Southwestern and being on faculty so that I could educate students and residents. But I didn't yet realize that I would end up educating them more about food than about how to practice medicine in the traditional sense. And it all started because of family members. And so these are my children from a past vacation that we took together. My husband is missing, but my husband and my son both have celiac disease. And when they were diagnosed, we got very little help about how to change our diets. And while we often think about metabolic disease being one of the main reasons why people need to make dietary change, people are facing food allergies and gastrointestinal illness and all kinds of things. Food is relevant to all of it. So that motivated me to go from the clinic to a kitchen. And I'll tell you a bit more about that as we move forward. But I want you to think about how everyone's food story, their family members' health, and all of those things weave a role in how we are able to make an impact on our communities. And then lastly, another big passion that I have, and I want to set the framing for what I'm about to share, is that fundamentally lack of access to nourishing food and the difficulty that it is for everyone, even people with resources, but particularly people without resources, is a policy problem. And we have to continually work around policy change at the federal, at state, and local level, while we also implement programs that help our communities do their best in the very broken policy structure we have. And this is a picture with leaders at American College of Lifestyle Medicine in Blue Zones, where we're beginning to try to form coalitions around shifting healthcare reimbursement and driving forward that how lifestyle health can be more accessible to all Americans. So you heard a little bit of this from Maria already, so I'm not going to belabor it, but for the nerds that want to see the references, this is extremely well researched that our diets are our top risk factor for modifiable early death in the United States, and this is also true globally, and it's driving nearly half of deaths related to heart disease, diabetes, and other metabolic health conditions. Diet is also directly contributing to most types of cancer. And then we know if we look at the adult population in the US, only 7% of us have what's considered optimal cardiometabolic risk, meaning that we're healthy in terms of cholesterol, blood sugar, our family history of cardiovascular disease. And so there's so much work to be done. It applies to almost everyone. And then a huge piece of this work is related to food insecurity. And I want to make a quick distinction that food insecurity and addressing social drivers of health is not exactly the same as food as medicine. They are related and overlapping fields. Food insecurity is providing, it's got formal definitions through the USDA, and you're also seeing it now being called nutrition insecurity or nutrition security. And I'll define food insecurity in a second, but it's addressing the specific food needs. Whereas food as medicine is how do we integrate interventions into healthcare that can transform health outcomes? And that applies to everyone, whether they're food insecure or not. Most people in this space agree that we should address those with food insecurity first and most urgently because they bear the highest burden of chronic disease risk. And then the last stat down here, I have trouble sleeping at night as a pediatrician, knowing that 1 in 5 children, and that this is true in my city of Dallas, Texas, are food insecure. So when we set children up for failure, starting at a young age by not having a societal investment in ensuring adequate access to food, it's no wonder that we are, in a pandemic of chronic disease in this country. So I think recognizing, the distinction between food as medicine intervention specifically and food insecurity, we have to recognize not everyone has the same access to food. So most of you, if I were in a room with you, I might ask, have you been to a farmer's market? Many of you would say yes. Have you been to a grocery store? Probably all of you would say yes. And we have those types of resources in most cases. And some of you who may live in more rural areas, finding a grocery store that's accessible to you might be a challenge. Here in my urban environment, having a grocery store is a privilege, and there are parts of our city that don't have one. And so we have to acknowledge where people are coming from. So I've actually done some research in the past with some of my interns where we've priced out what are the healthier food options available where my patients are getting their food, which is often a corner store. What do they cost at a corner store versus Walmart? And so just as an example, on this third picture I've posted, you see some oats on the bottom and you see some sliced canned fruit on the top, which I would say are both the types of choices I would encourage my patients to make. But we are finding that roughly most of these corner stores, their prices are roughly twice as much as if those were purchased at a traditional grocery store or Walmart. So choosing the healthier food options with limited places to shop is part of the problem for many of our patients. And then just to formally diagnose, or not diagnose, I'm using doctor language, to formally define food insecurity, if anyone hasn't seen this, I want to emphasize that this is a household level intervention. And that when we think about food RX programs, we have to remember that if there are children in the home, it may not be given to the adult. It may be given to the children. So even if the adult is the patient, that's something that many of us in the research space are trying to understand, is that how do we measure the outcomes of food prescription programs in a practical way when we know that food is going to be going to the entire family? And most people who are food insecure feed the children first. And just to speak briefly about the health connection here, food insecurity, as Maria also mentioned, is highly linked to chronic disease, but it's also this vicious cycle where people who are food insecure have to make trade-off choices. And that trade-off might be, instead of my medication, I'm getting food. Or that trade-off might be, instead of this healthier option that isn't going to stretch as far, I'm going to choose this option that's not as good for me, but it's going to help me feed the family and keep them from being hungry. And then and again, that's a policy issue, that the least expensive food is most accessible, subsidized at a federal level. We have a lot of work to do to improve some of these things. So then we move into chronic disease. Now that someone is sick, in part because of what's available to them to eat, a huge part of our health is tied to what we have available to eat. You're going to start needing more healthcare resources, which is either going to be a huge cost logistically, or it's going to become a time cost because you can't go to work. And now your household income goes down. And it's just this vicious cycle where it's very difficult for people to escape. So when we think about how to address this, the kitchen might not be the first picture you have. And most people actually might think first about a food pantry or providing, a food prescription. But I believe the kitchen has to be part of our solution because ultimately, provision of food that people maybe didn't previously have access to is often not sufficient if they've never known how to cook or prepare or minimize the waste of those foods. And so this is actually a group of students. These are future doctors. This is from several years ago, but we still use this kitchen. This is on our campus at the university to teach students and resident doctors how to prepare food. And we will often bring challenges where we'll have a food box about what's available at our food pantry locally, and then we'll give them health conditions, and they have to come up with a meal that meets the health conditions of that family based on what's available at the food pantry. So we're building skills into the next generation to think about food. And we might even say, hey, guess what? Look at that beautiful blender. You're not allowed to use that. You don't have one of those. And thinking through the skill set and the resources and tools that people have at their disposal. And so when you think about being in the kitchen, which we call this culinary medicine, which is a national movement now, not only in education, but now also to take this to patient care settings, there's three things that you can teach people. The more obvious is food and nutrition knowledge, which is as simple as, what is it that what are these foods? How do we know what they do for our body? And there's a whole language around nutrition. And that is where registered dietitians have the highest expertise and are able to really bring that to patients. But we also need people to have food skills. And sometimes that is something that will be talked about in a visit for diabetes with your dietitian or diabetes educators. But most people don't actually know how to translate that to a meal in their kitchen, at their home. And so that might be food preparation skills, what are food safety guidelines around, using the same cutting board for a raw chicken versus vegetables. Many people need to be taught those things. And then how does someone make food selections that prevent food from going to waste in their home? And especially if they're combining Wicker SNAP benefits, charitable food system benefits, and a food prescription to make it all work out for the month's food needs, they need help. And so I implore you, as you think about programs, to also ensure you're not just giving nutritional knowledge, but you're also maybe providing resources that help people learn to prepare food that can be sustained in their own family. And we've really found that people gain confidence and feel really proud of the skills that they develop over time when they are able to participate in cooking interventions. This is just an example of a community-based class that we regularly do out of our Cancer Institute. And so patients who participate are either caregivers of people with cancer or they have had a cancer diagnosis themselves. And if any of you have been touched by cancer, which I think is another thing most of us are touched by, it changes your relationship with food in not a positive way for most people. So how do we give that back and utilize both dietitians and other educators to help people get confident in both the nutrition and their cooking skills so they could do this at home? Some of the things that people say is that doing something hands-on makes it feel more realistic to then go back and do it at home. If you just hand someone a recipe, that is useful and valuable, but many people need to have it brought to life for them to feel confident. And then another big one that we're finding in most of our work in this area is how much people enjoy being around other people who have similar struggles. So it's an unintentional group therapy to go cook in a kitchen with other people who might be facing some of the same challenges. And we've seen a lot of community engagement and connection build out of that. And then some people say it's just the practical stuff like, oh, it was actually cheaper to cut the meat in half when I made tacos and use beans and mushrooms instead. And we liked it just as much. It's really empowering if someone can learn a skill and then teach their family how to do it. So just so you know, we don't have a beautiful teaching kitchen where we bring our patients. And that's one of the take homes I have today is the kitchen I showed you where all the patients were cooking was in Fort Worth, Texas. And this is the Dallas-Fort Worth area. If you're not familiar, we have these two big cities with a whole bunch of suburbs surrounding them. And then the 1975 kitchen where I showed you my students is not a kitchen where we can bring our patients. That one's in Dallas. But where are the patients who don't have access to a grocery store going to get support and services? So we don't have a beautiful kitchen down in the southern part of Dallas, but we have an amazing array of community partners. And so one of the my key take homes for you is you can do culinary medicine in the community. And in fact, that's the best place for it to occur because it's closer to where people live. And most communities have either a church, a school, a YMCA, or a community center that has a space that can be turned into a pop-up kitchen. And so we really learned about how much our patients wanted this in our earliest partnership, which was with the largest food distributor in the Dallas area called Crossroads Community Services. So they are really novel as a pantry where they set it up like a grocery store and people are able to choose their foods. And there's a selection system that's been designed by dietitians that help promote nutritious foods. They actually doubled that number. They've distributed over 50 million pounds of foods in some years because the need in our area is so huge, and they support about 150 pantries throughout Southern Dallas. So in our partnership with them, we had two key questions is, okay, they're providing food, but what do people actually want to eat or like to cook, especially when you're serving multiple cultures as we are in our area, and you're never going to be able to strike the right tone for everyone. And then back to the thing I was joking about the blender in our kitchen, what do people have at home? What do they not have at home? And how do we avoid discouraging them by giving recipes or suggestions about their diet when they don't have the kitchen resources? And so one study that we did, and that QR code should take you to the full poster if you're interested. But we started with doing food demonstrations based on our food pantry partners' preferences for inventory. So they would say, hey, we've got all this healthy food like a butternut squash or apples. And we have clients telling us they aren't sure how to cook these items. And so we would make recipes that fit those foods that were simple and easy to replicate at home. And then we would give out samples, kind of like you might go to Costco or Sam's Club, and people could decide if they wanted to take that food. And then we asked them some questions. We said, hey, we want to know what kind of items you have at home. And we created a pictorial graphic that allowed us to overcome language barriers where people could circle the items they had. And, we found some interesting things. A lot of people don't have measuring spoons of any kind. And so if I'm going to give them a baking recipe, they're not going to be able to do that. Baking's very sensitive to needing a measuring spoon, whereas maybe if you're cooking, you don't have to be exact about something that you're putting in. And then another one, we do a lot of teaching around roasting vegetables. If someone doesn't have a baking sheet, how are they going to roast some vegetables? And so learning about what your local community's resources are in the kitchen, not just the food needs, but the kitchen needs, helps people be successful long term. And another piece of this study was learning how passionate the clients were to have new recipes and to learn how to cook healthy food. And they gave us their grades or scores on different recipes based on what they'd like to cook and prepare at home for their cultural preferences. And then lastly, I just want to say that over many years of doing this work in partnership with the pantries and doing free classes, we began to realize that health insurance could pay for culinary medicine. And so if a patient has access to Medicaid, Medicare, or any other payers, and we're actually working on doing this through our county health system as well, we're able to bill health insurance for them to take group classes. And I'm not going to spend a lot of time on the first two types of our clinical activities, but shared medical appointments are a growing popular approach to addressing chronic disease, where you can bring up to 16 patients, and is my comfort number. Some people do slightly different amounts of patients into a space. And with physician billing, it covers all the costs of care if you have an ability to get reimbursed, or to do it through a value-based model where if you're trying to reduce costs for that population's care, it saves money over time. So this is actually a church kitchen through one of our partners in the South Dallas area. And I was able to get some grant funding to buy supplies to turn this empty room into a teaching kitchen. And we bring it, basically build it up and tear it down each time. And we're able to have patients attend a 6-part cooking class along with food prescriptions so that they learn what to do with the food that they are utilizing to improve health. And that's my last slide. And so, happy to share more, especially as we get to the discussion after our next speaker. But I just hope everyone feels like you don't need a beautiful, fantastic space. You can partner with the organizations that are already in your community, and they are eager to partner on helping educate to help people be successful in health behavior change around food. And I think I've successfully turned back the slides to you guys.
Thank you.
And we're gonna pass it along now to Dan. If you want to continue on with sharing a little bit of what your program is and all the great work that you do out of also in Fort Worth area.
Okay, perfect. Thank you so much, Maria. First of all, I would like to say that I am very honored that we were asked to be a part of this launch. I think that this is incredible. I think that food has been looked at in a million different ways in general, and I'm so glad that it's now being shown as a actual medicine, and that preventative is more important than, going to the doctor to get taken care of, get, your actual diagnosis taken care of. You can go to the next slide. I'm sorry, I'll keep blah, blah, blah. Hi, my name is Dion Jackson. I am a nurse by profession, also national certification in pharmacology. My background is not in food medicine. I have been here at North Texas Area Community Health Center for a couple of years. I have been serving in the community health center, and it's just been incredible. NTAC has had, you can go to the next slide actually too. That's just all about me, but it's not all about me. So Living Your Best Life has been here at Intact for a few years now. And it is a health preventative program that's more like an umbrella. And we do our food as medicine program and education under this program. And Living Your Best Life is pretty much moving towards the patient's individualized goals. We focus on holistic care approach. We start where the patient is, and then we just lift them to a healthy and whole state that is consistent with their personal needs and what they need at that time within their life. We also know that mental health is a huge part of health insecurity. And so we also want to make sure that we nourish that side of them also. And we always say, just like the roots of a tree, the roots of a person involve a lot of nourishment, attention, and care. And this is what we strive to give each of our patients here at Intact. Next slide. What I am going to kind of go over quickly, and I'm also going to share some links after I get done, is just how we have created our own food as medicine program. I always say that quality is much more important than quantity. We have a team of three, actually a team of two. I have Carmen Leveretta, that's also a community health worker and a nurse like myself. And then Gabby, that's a community health worker. And so we are doing this program pretty much on our own. So it is possible even if you're in a smaller clinic. So what is your why? Why do you feel led or called to see a change in your community's health environment? And our why is to assist in creating an individual, family, and community-based idea of eating to create a healthy lifestyle, because obviously, as we all know, learning outcomes by example. And if the parents in the community are showing an interest in living healthier, then obviously the children will also move that on into different generations. With the classes that we've had, family members do come and they bring their children also. Money and funding, that's also a big one. Dr. Albin brought that up. We have someone that assists us with our grants. But what I always tell people is you can use the funders or donors that you already have and just kind of tack this on to get additional funds for the program. There are definitely some components that I'm going to talk about that you need to keep in your back pocket so that if there is ever a donor or someone that wants to give you a grant for your food assistant program, you already have it prepared. Okay, let me see, sustainability. Next slide. Perfect, right there. All right, so target population, this is also important. It's who do you want to serve first? You can use priority, need, or your preference. We chose to focus on our pre-diabetics. Um, so people with a hemoglobin A1C between 5.7 and 6.4, just because we already are seeing our type 2 diabetic patients on one-on-one educational classes daily. Next slide. Partnerships. So earlier this year, I don't know if you guys heard about Tarrant Area Food Bank and CVS in one of the largest launches of Food is Medicine and one of the largest grants that were given. We were chosen as one of the partners. And so we did partner with Tarrant Area Food Bank from April to September. And we had 25 patients that we had to use. There were a lot of different things, guidelines that we had to follow. We came up with about over 70% that had a decrease in their hemoglobin A1C. And I'm going to go over the different things that we did within the program. But partnerships, so is definitely a program choice. Do you want most of the responsibility or do you not want most of the responsibility? Also, you need money to do anything. And so when you get within that partnership, you want to make sure that you ask how much funding you're getting on your behalf within the partnership. And then you can use that money to do what you need to do in order to not only assist within the partnership, but also to help yourself move forward in things. Okay, next slide. Staffing is also highly, highly, highly important because what you'll find is everything looks very simplistic on paper, but once you implement it and you get it into motion, you find out there are a whole bunch of other little arms and fingers. And so you definitely want to make sure you know how many additional people you will need to pursue the program, who should or should not be involved, ancillary people versus clinical people versus others in the community. Are you willing to put some of your time into these efforts? Because remember, we definitely start with boots on grounds. We reach out to the community and bring our patients in from the community for these different programs. We also think that relationships with the community are highly, highly important. And so we include all of these different areas within our company. Also, how many additional hours will this project take? You always want to at least place 1 to 1.5 additional hours for the unknowns. And then next slide, space. So space is also very important. We do all of our programs at our new center. We do not have a kitchen. We pretty much take one of our classrooms and we've set up our classroom not only to be a kitchen area, which, by the way, we also have a sink right next door because we know there's a lot of different compliance things that you have to follow. But anyway, we have a sink and we have a refrigerator. We use hot plates and we use the classroom not only for our cooking demonstrations, but also the educational components. We just do everything right there in that same room. You also want to make sure, is it an adequate amount of space? So like fire hazard, how many people can be in the room safely? Those different types of things. Next slide. Supplies. This goes with the annual budget. So you want to make sure that you map out the program, which will entail all of just the supplies only. And then also how much will these supplies cost? That's going to be also very important. And then you want to break it down annually, quarterly, monthly in each class. All these different things that I'm speaking about, we have already done. We do a lot of spreadsheets. I think when I say spreadsheets, my staff freaks out, but that's the only way. You want to think ahead. And so if you don't have the structured components, if you don't have all of the data and your KPIs, then when you do get those donors, when you do get recognized and people say, oh, I want to give, I want to do this, they're going to want to see statistics. And so you need to start with the statistics. And so if you ever have to go back, you'll have all of that information. Okay, next slide. All right, so education channels, curriculum, also very important. We are DSMES accredited, and you want to make sure that the educational pieces that you use are evidence-based. And so you want to set up a curriculum. Are there going to be packets that you're going to be giving to the patients? You want to make sure that you have the packets in English and in Spanish if you need them in both languages. Will you be using PowerPoints, hands-on? Different demonstrations, teach and repeat. Are you going to use games? Knowing exactly what type of channels you're going to use, because you have the kinesthetic learners and the visual and the auditory. You want to make sure that you touch all of them, and you also want to make sure that it's as simplistic as possible. Yes, you may have studied this information and you may know this information, but remember, these patients are coming to you not knowing really anything from a starting point. And so you need to make it as simplistic as possible. Next slide, please. Perfect. What languages will the information or classes be taught in? We have had some classes where we do English and Spanish simultaneously, and it actually worked out pretty well. And then because majority of our patients are Spanish speaking, majority of our classes are taught in Spanish. At what level will these classes be taught? Do I have the staffing to meet the needs to do the teaching? And can we do two languages at the same time, which I already spoke about? Next slide. All right, so class schedules, that's another thing that you'll want to think about. When we were partnering with Tarrant Area Food Bank, we did every Thursday from 5 to 7. Okay. And so with that being said, that meant that the building, we had to worry about letting the building manager know, letting police officers know, because we were here after hours. And so when you create the class schedules, you want them to be appropriate for your staffing, appropriate for the patients, appropriate for everyone involved. With the class that we have just launched, which is our pre-diabetes class, we're doing those every second Friday of the month, and we have a 9 to 11 class and then a 3 to 5 p.m. class. And so schedules are very important because you want the patients, obviously, to have the ability to come in, because SDOH, once again, is a huge component that you'll want to make sure that you focus on. Next slide. Patient incentives. So do they want to just come to an empty room? No, they don't. And so we have little swag bags that we give out, and we have these little measuring cups that we put in the swag bags. We also have recipe books that are in Spanish and English that we give to the patients that they can take home. If they reach their goal, they get a gift. So patient incentives are also very important. We also let them know their hemoglobin A1C at the beginning of the class, and then we let them know their hemoglobin A1C once we've completed the entire program so that they can see the changes, and we, discuss those different things. Next slide. And then realistic goals. Like I said, it's highly important to remember that it is quality over quantity. So it always looks good on paper. You want to start off small. We have about 10 to 15 patients that we see in our pre-diabetes class, which is completely, it's without partnership. That's our actual in-tax class. And you can tell I'm a nurse here. Assess, plan, small goals, large goals, implement, evaluate. And the evaluation, remember, can be done at any part of the process. You just want to make sure that you don't set yourself up for failure. Also, statistics are highly, highly important, because the best way to evaluate is objectively, not subjectively. Anyone can say, oh, the class was wonderful. We had a million and trillion patients come in and they were hanging out the doors. But if you don't have any proof of, their hemoglobin A1C decreasing and their blood pressure decreasing, then, nobody's going to really believe anything, right? Next slide. Continued evaluation. So have a comedian. This is also very important debriefing. So after, kind of like after we did the Tarrant Area Food Bank 6 months, and by the way, they've asked us to repartner in February, which we're kind of trying to decide whether we're going to do that. But after we did that, we did do a debriefing, and that's how we came about, you know what, let's start our own class and see how it works. And so that's where we are right now. You know, can you go bigger in size? Should you stay where you are? Can you go smaller? And then next slide, positive outcomes. And so you want to make sure these are the pieces: being dedicated, structured, organization, being consistent, being reliable, and then also being open-minded is highly, highly important. And remember that you're there to serve. Okay. And that's it for me. Thank you.
Thank you so much, Dion. And we will pass it now to Cassandra Hunt.
Hi, thank you guys so much for having me. I'm also very honored to be included in this, and really honored. Thank you to both of our speakers, Dion and Dr. Alban, for sharing all of your knowledge with us. I think it's so important, and you both have really valuable information to share. I'm going to go really quickly so that we have some time to address the questions that have been put in the chat. And so just really wanted to give a brief, very, very brief overview about food as medicine. Both of our speakers have already talked about what it is, what is, how, and also how to implement it, and how do you begin or start to think about these programs in your own health centers and in your community organizations or your health departments, wherever you are working. So I really just briefly want to talk about the food as medicine, which is, I believe Dr. Alban already gave that definition, but it really is providing healthy food resources to treat, manage, and prevent certain conditions in partnership with your healthcare providers. And so we are aiming to address the gaps in the study of current food as medicine interventions and have launched this Healthcare by Food initiative. So I'm going to drop the links in the chat, and that's as much as I'm going to say about it. So we have time to get to some questions. Some of the work that AHA has done with our clinical and community partners, and really trying to connect those mobile markets. In some instances, it may be farmers markets, but those mobile markets, and connecting those local produce growers with the clinical partners who want to provide these options and these food prescriptions for their patients in such a way that they have a direct access, a place to access those things if they don't have a grocery store, or their local corner store does not, provide all of the produce that they need. And so some of that work are things that we have done. And again, focusing education on integrating produce into meals. Dr. Alban mentioned or spoke about that, and that is something that we've seen in some of our community organizations and our food banks and food pantries, where they can tailor recipes, and again, providing those samples, providing recipes that integrate those specific foods. So with that, I'm going to move on to our question session, and ask Dion and Dr. Alban both to join me. And first, I wanted to talk about the cost. And so there was a question in the chat that asking specifically about hosting an SMA at a community site. And is it true then, so you can still bill or for reimbursement, that can be reimbursed even if it doesn't take place at a clinical site?
So great question. And as somebody who is always kind of trying to make up new pathways when I think the current ones don't work, that took some effort, but we figured out that as long as the health system has a lease agreement, which I literally wrote myself, but got approved through the right channels, with the community site, it's just like renting an office space that becomes a clinic. So the church kitchen becomes my hospital system during the hours that we rent the space, and you just pay a very simple CMS designated rate. And then that plus a sign designating the health system affiliation, and we just use one of those little pop-up, I don't know what you even call those little signs that are like this, and bring that sign out. Those two things, lease agreement on paper, CMS leasing rate, which is not very high, and then assign, makes it a site of service for those hours, and then I can bill any health insurance payer. And so I think someone also asked, it does take physician billing for this. I work with a dietitian who's also trained as a chef, but I know other physicians who have extensive nutrition training that will partner with a local chef or even a culinary student. And so you can use a variety of learners. The culinary medicine community is trying to designate the different team structures that work best, but you need someone with nutrition expertise, someone with culinary skills, and then the actual person who can bill.
Thank you so much for that clarification. There was
And
also,
that's only if you want to make that a healthcare entity. Somebody who does this for education for any community doesn't have to have those people involved if they're not trying to bill health insurance.
thank you. Thanks so much for that clarification. Yeah, it is very creative. I always admire and appreciate the creative capacity of our healthcare providers and our health systems and our community organizations. I really love that. And I also, the idea of going to where people are already, meeting people where they are in those community spaces where they're potentially already going to be is really helpful as well. So I want to really quickly jump to asking about, can you expand a little bit more on the education? And I think that there was also a question about this, the curriculum for the pre-diabetes classes. Are they cooking demonstrations or other content? And Dion, this was during your portion, but I'd welcome both of you again to chime in on this. What educational materials, sources, what are you using for those patient or client educational materials?
So what we're using, and I've placed like a bazillion links for you guys on the chat. What we're using now is the CDC On Your Way to Preventing Type 2 Diabetes. And what it is pretty much an entire breakdown. Like I said, you want to be very careful. Make sure that your information is evidence-based and that it's not subjectively created. And so what we've done is we've pretty much taken those packets and put a little twist on them and created a PowerPoint. And then we also have a hands-on packet that they can take home. They have this information in Spanish and in English. We've made it into a QR code so the patients can keep it on their phone. And then as far as getting educational things, we use NASCO and then also Get Visualize to get and we use MyPlate. That's another thing that we use in order to do a lot of our teaching, because we use MyPlate and all of their different things in our type 2 diabetes classes, educational classes that we do one-on-one. But like I said, you want to make sure that you give them all of the things that they need in the class when they walk through that door. And so we do give them a swag bag. They get the little measuring cups, they get an educational packet, a notebook, and a pen. And then we also do some hands-on cooking. And you need to also have it separated. So you have the PowerPoint where they can focus, and then you have the hands-on where you talk about with the actual MyPlate, all of the different ways that you can change your food around. And then we use the recipe book and we do hands-on cooking, and they volunteer and join in. So I hope that answered everything.
Yeah, fantastic. Dr. Albin, anything else you wanted to add about as far as curriculum goes?
Just that you don't have to reinvent the wheel. And I think Dion's resources are great. You don't have to write your own thing other than tailoring to the socioeconomic and cultural needs of your population. You just start with the frameworks that are widely available. We use a national culinary medicine curriculum in our program and then tailor it to the local preferences, if you will. So there's so many great resources out there.
Fantastic. Last question really quickly, and then I'm going to pass it back to Maria to wrap this up. But I just really quickly wanted to ask about technical assistance, training and technical assistance. I know that NCFH provides this as well, but what other resources could you point anybody who is wanting to start this? What other resources did you all utilize? It sounds like a lot of it was creativity, trial and error, finding things. What places can people go for technical assistance? I'll kick it to either of you. Sorry.
I mean, I'm just going to say everyone is making this up as they go. And I loved Dion's very structured and thoughtful, like, these are the things you need to think about. So I would take her slides and start there. And I also loved her advice to start small. And most people want to start with this big, beautiful, massive program, but you start with 5 people a week and then you go from there and you will learn. I mean, I've been on the ground doing this work for almost a decade, and I fall on my face still once a month because you will learn something new that you haven't thought of before. So I think you simply just have to begin very small. And initially, due to lack of resources, that was what led to my food pantry partnerships, because I thought, how can we actually support people who are already getting charitable food assistance and help them make the most of that with their culinary skills? And then we were able to build eventually where we're writing grants that give our food pantry partners more resources to experiment on the foods that they have available. And so it can build over time, but it doesn't start there. It starts with just a super small, you're probably going to mess it up experiment. And so I think, we're giving you well-developed programs, and I know that can sometimes be overwhelming, but it just shows you what's possible when you start small. I don't know if you have other things, Dion. I mean, there isn't really a one-stop shop or hub.
There
We all
really
literally
isn't.
just
You
make it
said
up
it
as we go.
perfect. But you really have to, and start small. That's what's so funny. I was laughing because they wanted, oh, let's start with 20 people. No, we're going to start little, and then you grow as you go.
And then I just want to make the encouragement that I said at the beginning, that this is a policy problem and it is hard for everyone. And I loved the comments that someone was sharing in the chat about, this is hard to do in my own life and I have the education. I hear you and I totally agree. And it's about small change, not letting perfect be the enemy of better, and then helping people feel empowered. And if you have children, I've trained my kids to help prepare food. And so I think a big piece of it is, how do we get the whole family involved in simple things? And one of our simplest, like, throw together dinners at my house is canned beans on corn tortillas with whatever vegetable we happen to have on top and some salsa. And we call it bean tacos, and the 10-year-old can make it. So I think we have to build those skills into our own lives and our patients and communities' lives so everyone feels empowered to have more options.
Thank you both so much. Maria, I'm going to turn it to you.
Thank you all so much for participating in this webinar today. I wish we would have more time. Like, we have to do a second part to this, because I enjoyed so much this conversation, and there's so many valid and good questions from from all of us that we still have, and that I'm sure we can keep on learning from each other and building on each other's knowledge and lessons learned and best practices as well. So thank you so much. The evaluation is in the chat.